Welcome. In this series of videos, we'll discuss weight-related bias and stigma. We have 3 learning objectives for this topic. Within this video, we'll discuss the prevalence and consequences of weight-related bias and stigma. We've explored many examples of weight-related bias and stigma, and we know that these aren't just random anecdotes. Weight discrimination is a prevalent phenomenon despite high rates of overweight and obesity. This figure here displays data from a study of weight and other types of discrimination in the United States. On the x-axis, you have different characteristics for which individuals may be discriminated: gender, race, age, weight or height, appearance, and ethnicity. So this allows us to compare experiences of discrimination based on these characteristics. On the y-axis, we have the percent of study participants who reported they experienced each type of discrimination. In the lighter gray bars, we have data for men, and the darker gray bars, we have data for women. Data illustrated that the prevalence of gender, race, and age discrimination were the most experienced, and in particular, we see that women were much more likely to report experiences of gender discrimination than men, whereas men were more likely to report experiences of race discrimination than women. Men and women were equally likely to experience age-based discrimination. We can see that 28% of women reported experiences of gender discrimination, whereas we see 16% of men experienced some sort of racial discrimination. We can compare these experiences with that of bias related to weight or height or appearance. And here we can see that around 5% of men and 10% of women report they experienced discrimination based on their weight or height. We also see that around 9% of men and 3% of women reported they had been discriminated against based on their appearance. However, it's important to note that this is a sample of Americans aged 25 to 74, but these responders were not grouped by their weight status. The story changes slightly when we look at experiences of discrimination for different weight status groups. Here we see from the same study the data broken down a different way, where we compare perceived weight or height discrimination for adults whose BMI was classified as normal weight versus overweight versus moderately obese versus severely obese. Here we see the different categories, the sample size for each category, the percent of each weight status group that reported experiences of weight or height discrimination, and these same reports broken up by men versus women. When we look at the data for the total sample as well as by men versus women, we see some interesting trends. First, as might be expected, we see that the percent of adults who experience weight or height discrimination increases with weight status. 14% of adults with a BMI classified as moderately obese and almost 40% with a BMI classified as severely obese have experienced weight or height discrimination. We see that significantly greater proportions of women with BMIs classified as obese report experiences of discrimination compared to men. The most affected group is women with BMIs classified as severely obese, and here we see that 45% of these women report that they've experienced discrimination based on their weight or height. So the data we just looked at were for adults, but we can ask the question of where does this begin? Do we see children discriminating against other children based on their weight, shape, or body size? Let's look at the results of one interesting study that can provide us with some answers for this question. This study was originally conducted in 1961. They recruited 10 and 11-year-old boys and girls who were in the 5th and 6th grades, and they gave these children 6 drawings of imaginary children. One was a healthy child, one was a child on crutches, one was a child in a wheelchair, one was a child missing a hand, one was a child with a face deformity, and one child was heavier than the rest. These boys and girls in the study were asked to rank these figures according to how well they liked each child. They weren't provided with any additional information about these children, so they were making their judgments based on appearance alone. So after learning about the methods of this study, what do you think? Who do you think they ranked first? Who do you think they ranked last? Remember that this study was conducted in 1961, prior to the increases in obesity that we've seen since the 60s. So make your best guess about what these children did. This figure illustrates the results of this study. The terms on the figure correspond with the different children that the study participants were shown and asked to rank. On the y-axis, you have the mean ranking that each image received. And here you can see that on average, children in the study ranked the healthy child the highest, second was the child on crutches, and third was the child in the wheelchair. Fourth was the child who was missing a hand, and fifth was the child with a face deformity. Last was the obese child. This is a clear example of weight-based discrimination. Based on appearances alone, the children in this study ranked the obese child as the one they liked the least. The researchers replicated this study in 2001. If you remember, between the 1960s and the 2000s, we saw stark increases in the prevalence of obesity and much more public discord around the obesity epidemic. So what do you think? If this study was conducted in the exact same manner with 10 to 11-year-old children in the 5th and 6th grades, with the only difference being that these children were living in 2001, do you think the results changed or stayed the same? Let's take a look. So here we see the contrasted data between 1961 and 2001. What we see is an even greater disparity between the top-ranked healthy child and the bottom-ranked obese child. There's some shuffling around of the other children in the middle. So now in 2001, children ranked the healthy child the highest, the child with a face deformity second, the child with crutches third, the child with a missing hand fourth, the child in a wheelchair fifth, and the obese child as far last. The asterisks indicate that all of the rankings were significantly different between 1961 and 2001, showing clear changes in weight-based discrimination between these time periods. So now that we have established that individuals with larger bodies experience weight-based discrimination, let's take a moment and reflect. Take a minute to think about your own experiences. Have you experienced discrimination? This could be discrimination related to your body shape or size, or any other sort of bias or stigma related to your gender, your age, your race or ethnicity, or any other characteristic. Likely all of us have experienced some form of bias or stigmatization and resulting discrimination. Can you remember how it affected you in the moment? How did it affect your future behaviors? Some of what you reflected on may parallel what we'll discuss here. In general, research shows us that weight-based bias and stigmatization negatively impacts health outcomes. When individuals experience weight-based discrimination, a common consequence is feelings of stress due to the discrimination and the negative interactions that result. This stress can affect eating and physical activity behaviors. Research has shown that individuals who report these experiences cope with the resultant stress in a variety of ways, including binge eating for comfort. Some also respond by trying to meet expectations that are communicated by these biases and stigmatizing experiences. They may use maladaptive weight control strategies, such as fad diets, to try to reduce their weight to meet societal expectations. Experiences of weight bias and stigma also increase engagement in disordered eating, such as binging and purging. Lower levels of motivation for health-related behaviors, such as eating healthfully and exercising, and lower levels of physical activity also result. Taken together, all of these are counterproductive, especially if we are trying to support someone to achieve their health goals. We also know that stress has physiological effects. So if an individual frequently experiences weight bias and stigmatization, the resultant stress means that they have increased levels of biomarkers of stress, such as cortisol, all of which have negative impacts if sustained chronically. We also know that weight bias and stigma affect the quality of health care, both in terms of self-care, or the activities an individual does to take care of their own health, as well as in the form of clinician-patient interactions. We see that individuals who report experiences of weight-based discrimination in healthcare settings have poor adherence to their prescribed treatments. They also have poor disease self-management. This means they're less likely to take their medications regularly or do things like manage their blood glucose levels effectively. They're also less likely to follow through on their doctor's recommendations. Individuals who experience discrimination also report less trust in their providers, likely because they have negative experiences with them and feel judged in their presence. They also avoid follow-up care with these medical providers, and they delay preventive healthcare services. Overall, they have less communication and less effective communication with their providers when they feel discriminated against, and we know that all of these things can increase stress levels because they reduce health and quality of life. These factors, both individually and combined, affect both physical and psychological health. Research has shown the consequences of this weight bias and stigmatization and the resultant effects on stress and health behaviors and healthcare result in increased risk for weight gain, poor glycemic control, and these individuals have more advanced and poorly controlled chronic diseases because they aren't engaging in preventive screenings or effective disease self-management. Overall, they report lower health-related quality of life. In terms of psychological outcomes, experiences of weight bias and stigmatization are associated with greater levels of depression, lower feelings of self-esteem, poor body image, substance abuse, and suicidality. We know that psychological and physical health are connected, so these experiences of poor psychological health increase risk for poor physical health and vice versa. Of particular concern is the fact that experiences of weight-related bias and stigma increase risk that individuals will internalize these weight biases, which further worsens the negative effects of bias and stigma. Internalized weight bias is defined as individuals' belief that they deserve the stigma or the discriminatory treatment they experience as a result of having obesity. So essentially, when an individual is repeatedly told by society, either directly or indirectly through people's actions and non-inclusive environments, this increases the risk that the individuals with a larger body will start to believe these messages and devalue themselves based on their body shape and size. Thus, this is an important mediating factor between experiences of weight-based bias and stigmatization and psychological maladjustments. When these experiences result in personal devaluation, then we see an especially increased risk for depression, poor body image, low self-esteem, and avoidance of preventive health care. We know that there are certain individuals who are likely more vulnerable to weight bias and discrimination, and research has investigated which individuals are more likely to report high levels of weight bias internalization. That is, greater feelings that an individual's worth is related to their body shape and size. We see that individuals who are white, who have lower education and income levels, who are currently trying to lose weight, who have higher BMI, and who are previous targets of weight stigma, report high weight bias internalization. Research also shows that 20% of the general population reports high weight bias internalization, but this prevalence is even higher when we just look at individuals whose BMIs are classified as obese. Slightly over half of these individuals report high weight bias internalization. Unfortunately, when weight bias occurs in clinical contexts, it detracts from the services that we may need the most. Research has shown that weight bias negatively affects the quality of clinical care. Of particular concern is research showing that significant proportions of healthcare providers have both explicit and implicit weight-related biases. In particular, they report that they associate larger bodies with laziness, lack of self-control, lack of willpower, personal blame for the weight, and increased likeliness of non-compliance with treatment, and that individuals with larger bodies are deserving targets of poor care. These trends are concerning, but even more concerning is that these assumptions predict patients' report of lack of empathy from their healthcare provider, less thorough evaluations, inaccurate attribution of health problems to weight, and overall poorer quality of care. When weight bias affects the quality of clinical care, it means that we're failing to help the people in environments and contexts with the most potential to support their health-related goals. And perhaps most importantly, we should note that weight shaming does not motivate positive behavior change. It's counterproductive, and it makes us less effective in our roles as healthcare providers. So let's review some key takeaways. First, we see that almost half of individuals with severe obesity report experiences of weight discrimination. Research also shows us that these weight biases and stigmatizations increase stress and also increase risk for weight bias internalization. Both stress and weight bias internalization are important mediators that impact our risk for poor behavioral, psychological, physiological, and metabolic outcomes. When individuals with larger bodies experience weight discrimination in healthcare settings, it decreases the quality of care that they receive, and also decreases their likelihood of coming back or communicating effectively with their healthcare providers. Therefore, recognizing sources of both explicit and implicit weight bias in these settings is important, as is understanding how we can make these settings more inclusive and comfortable for individuals with larger bodies, so we can effectively help them meet their health-related goals. That's all for this video. Thank you for learning with me.